Good afternoon. I think we'll get started. It's just 3 o'clock, and we have lots of material to cover. I'm Kathy Geese from Brigham and Women's, and I'm speaking here today with my colleague, Dr. Diane Georgian-Smith. And I'll tell you a secret. We are talking about two areas that I think we each have a little obsession with. I'm obsessed with asymmetries, and she has a little obsession about distortions. So we were delighted to get these respective topics. So for the next few minutes, I'd like to briefly review the ACR BI-RADS definitions of asymmetries and the literature. And I'll show you a bunch of benign and malignant asymmetries, and finally review some strategies for the detection and evaluation of asymmetries on both full-field digital and tomosynthesis. Do you want to start my time? So as we all know, asymmetries are defined in the BI-RADS manual as an area of fibroglandular tissue that is not conforming to the definition of a radiodense mass. There are 4 types included here: asymmetry, which is a one-view finding; a focal asymmetry, which looks similar on both of our 2 standard views; and then global asymmetry, and my personal favorite, the developing asymmetry. I hope to share some of my enthusiasm with you. So an asymmetry, as I said, is seen only on one of our 2 standard mammographic views. A lot of the early data on this we owe to Ed Sickles. He has demonstrated that asymmetries, or one-view findings, are present in a little over 3% of our screening mammograms. Most of them are due to summation artifact, either determined purely on the screening views or on subsequent diagnostic workup. And they're rarely malignant. Under 2% of them prove to be malignant. And this is just an example of an asymmetry. You can see on the CC there's an apparent finding, which on the MLO view you can see is just comprised of this varying areas of fibroglandular tissue, which are at the similar depth and compressed together make a pseudolesion. Another example of an asymmetry. Here in the middle is her 2012 right mammogram, and she has an apparent one-view asymmetry here lateral to the nipple. This is her 2011 study, so it looks new, but my technologist did an XCCL view just to get more lateral tissue, and you can see the finding is spurious. On the other hand, this is a true asymmetry. This is a 62-year-old who has this one-view finding centrally on her right CC view here. There's really nothing at that appropriate depth on the MLO view. She underwent these both rolled views, rolled lateral and rolled medial. They serve to show you that not only is it a real finding, it holds its shape, but it doesn't move much. It's central on both those views, and that indicates that it's actually truly in the central breast, in this bland, innocuous-looking tissue. Her ultrasound was negative, and she underwent stereotactic biopsy, which showed a mixed invasive ductal and lobular cancer. This is another one-view asymmetry. An astute colleague of mine picked up this finding lateral to the nipple on the CC view. Who knows where it is on the MLO view? There's tissue at the appropriate depth at multiple levels. She was recalled for workup. CC spot view up above makes it look real. Hard to tell if there's really something there on the MLO spot. She had a negative ultrasound as well, and the finding turned out to localize to the upper breast on biopsy. This was an invasive ductal cancer. And we'll speak a little bit more in a few minutes about the ultrasound evaluation of asymmetries. So a global asymmetry, as we know, is a large amount of fibroglandular tissue, typically occupying a quadrant or more of the breast. It should have no associated mass, distortion, or calcifications with it. It is found in about 3% of both screening and diagnostic mammograms in a pooled population in Dan Copan's study, and it's usually a normal variant, and it's rarely malignant as well unless it's palpable. Just a nice example of a global asymmetry in this patient. She has much more fibroglandular tissue on her right MLO view than she does on her left. This was a normal finding. On the other hand, this patient also has more fibroglandular tissue centrally on her right breast. She has a palpable finding indicated by the BB and also associated nipple retraction. This was a very large invasive ductal cancer involving most of the central right breast. So the third type of asymmetry we talk about is a focal asymmetry, and this is a two-view finding that has a similar appearance on both the CC and the MLO view. In other words, it's not due to superimposition. Typically, it's less than a quadrant of the breast, and it lacks those convex or outward margins, in which case you might consider it a mass. It often has concave margins and often has interspersed fat. It's an uncommon finding. Again, thanks to Ed Sickles' work, less than 1% of our screening mammograms have focal asymmetries, and it is also rarely malignant. This is an example from our practice. This 40-year-old on her baseline had this focal asymmetry here, medially, and in the posterior left breast. It localized to the upper breast on the MLO view. She had a negative ultrasound, and she was placed into 6-month follow-up. This has been stable for a number of years now, so just a normal finding. Similarly, this 54-year-old has a focal asymmetry indicated by the arrow, stable for many years. You'll note that it has concave margins along some of its aspect, and it's interspersed with fat, so just a benign finding. However, when these focal asymmetries have associated findings, as this example does here in the arrow, it has more significance. This patient has the suggestion of some distortion in this focal asymmetry, as well as some punctate calcifications, and this was a malignancy. So the developing asymmetry, my favorite because it's so challenging, is a focal asymmetry that is either new, larger, or more conspicuous than a prior examination. It is, fortunately for us, a rare finding. Less than 1% of both our screening and our diagnostic evaluations have developing asymmetries. But the incidence of malignancy for a developing asymmetry is much higher than our other 3 types. In Jessica Leung and Ed Sickles' work on developing asymmetries, the range of malignancy went from 12.8% in the screening population to 26.7% in the diagnostic population. And this study here from our institution, led by one of our former fellows, Alison Chesbrough, showed a 15.4% malignancy rate for our developing asymmetries, and that was in a mixed screening and diagnostic population. So it was a much more significant finding for the patient. 6% of our non-palpable cancers present as developing asymmetries, so it's an uncommon manifestation of breast cancer. And this is an example of a 63-year-old whose screening exam here in 2011. I've given you her 2010 CC view, so you can take a look and see if you see the developing asymmetry. Happens to be here, just lateral to the nipple line. It's not really visible on her MLO view, but on evaluation, this was here. I've actually got a close-up of it. You can see that it's a little dense for its size, but it also has some fat running through it and a concave margin inferiorly. This was a little invasive malignancy. Sometimes a focal asymmetry turns into a developing asymmetry. This patient has a stable focal asymmetry for many years here in her inferior central breast. I've shown you 2009, but in 2012, it starts to get larger and becomes palpable. And on evaluation, she has an ultrasound correlate. This was an invasive lobular cancer that arose in this island of fibroglandular tissue. So what's the problem with asymmetries? Why are they a challenge? Well, if you look at the missed breast cancer literature, 9 to 38% of missed breast cancers initially present as one-view findings, asymmetries on the prior mammogram. And so the challenge for us is that they're very common, they're not usually malignant, and they look really innocuous. They look like an area of fibroglandular tissue, so there's a natural temptation to kind of pass them by. So my 15-year-old is a natural history buff. We talk about these things all the time around the dinner table, and it's sort of the opposite of Batesian mimicry, which, to remind you all, in the animal kingdom, sometimes you have a toxic species like the pipevine swallowtail. It's poisonous. And a benign species, a non-poisonous species, may mimic its appearance in order to escape predators. But in our instance, this is a reverse because the malignant developing asymmetry is much less common than the areas of fibroglandular tissue we see all the time. So how do we tell them apart? Well, tomosynthesis really helps a lot, as we've heard yesterday in some of our tomo talks. We know that tomo separates out our summation artifacts, and in the screening population, our false positive recalls, many of which are asymmetries, are reduced using tomosynthesis. And these are 2 studies, both from the Brown group, led by Anna Lorenko, and the Yale group, Melissa Duran's work, showing when they looked at what their percentage of callbacks were, they found that asymmetries went from 32% on full field digital down to 13% on tomosynthesis, and their focal asymmetries, their 2-view findings, went from 32% down to 18.2%. And in the Yale experience, similarly, the percentage of their callbacks due to asymmetries went from nearly 60% down to 40%. And this is just a table of the Yale experience. So overall, their recall rate went down significantly from full field digital to tomosynthesis. And similarly, the total percentage of their screening exams that were recalled for asymmetry went from 7.4 to 3.1%, and that was also statistically significant. This is the Brown group, Anna's data, showing you again that there was a significant decrease in the recalls for asymmetries or one-view findings and two-view findings, focal asymmetries. And just a case from our practice, this patient developed a little one-view finding, an asymmetry at the fibroglandular fatty junction near the Milky Way. She's quite heterogeneously dense. It wasn't visible on the MLO view, but we could localize it to the lower breast by using that tomosynthesis localizer tool, and that guided ultrasound evaluation showing a small hypoechoic mass, small invasive cancer. Tomo is really helpful in this example for showing you a summation shadow. Here in a 2017 study, this patient has a little one-view finding. It looks actually a little spiculated to me. You can see it wasn't there in 2015, but if you look at her Tomo clip, looking right here, you can see that it crosses, it's just two crossing bands interspersed with fat. This was just a benign finding, no need to recall. On the other hand, this is a real developing asymmetry. This was, I think, a really great pickup by one of my younger colleagues, Dylan Quate. He called back this asymmetry, focal asymmetry, but it's actually a developing asymmetry if you look at her 2015 study. I think the finding's easier to see on the MLO view than the CC view. He recalled her for workup. And so if you just look here, I think this is hard. This is actually interspersed with fat. It looks like an area of fibroglandular tissue. Here's her CC tomo. So I think this case illustrates another important point. Have a low threshold for going to ultrasound. This looked new, and he did an ultrasound and found a correlate, and this was an invasive ductal cancer. Similarly, this case, I think, also illustrates that point, and I hope that's one of my take-home points, to have a low threshold for doing ultrasound and evaluating these developing asymmetries. This patient was recalled for this finding here in her upper right breast on her MLO view. You can see in 2014, it really does look different. But on the 2D spot view, is there a finding there? I don't know. To me, that looks quite similar to 2014. Now, when an asymmetry doesn't have any distortion or associated findings, it can just blend right into that surrounding fibroglandular tissue on Tomo. So Tomo's not going to be 100% for us. If you play her movie, you can see she's got an area of fibroglandular tissue here. Now, the CC view helps a little, right? There's a little bit of density out there. But again, this particular developing asymmetry has no distortion in it. So low threshold, right, because it rolled into the surrounding tissue, low threshold for going to ultrasound. There's an obvious correlate, and this was an invasive lobular cancer. The Tomo really helps show us when there is some associated distortion with these developing asymmetries, even when the breast is fatty. And in this particular case, she's quite fatty. She has a little developing asymmetry here and here, and I've shown you just the Tomo slices. I think you can appreciate the spiculation, particularly on the CC view here. Just another little invasive malignancy. So Tomo, I think, helps a lot in terms of showing us the margins if they have any associated distortion. Just another example of this patient. She's fairly dense. She has a one-view finding here. It looks a little nasty, right? On her Tomo slice, you can really see the distortion quite well. These are two spot views. This is the CC spot, and here's the MLO spot, and so it actually localizes to this area on the MLO view. So I want to spend a few minutes talking about synthetic mammography. We heard a fair amount about that yesterday, both in the panel and in the Tomo talks. How does this help or hurt us with asymmetries? Well, as you know, the synthetic algorithm is used to synthesize a 2D image from the Tomo data set. And the algorithm identifies slices and regions that contain calcification-like or lesion-like characteristics. And it's not an exact replicate of the full field digital because it's designed to give extra weighting to the slices with those calcification-like or lesion-like features so that they are enhanced to our eye. And it's supposed to make masses, architectural distortion, and calcifications more visible to us. And the rationale, of course, when we went to tomosynthesis, we got all the benefits of it, but we doubled the radiation dose. And in this era, that's not the way we want to go. So if we can really accept the synthetic mammogram in place of the full-field digital, we gain all the benefits of tomo and reduce the dose back down to what we were used to with full-field digital. But how does it perform? Well, this was a large multi-center retrospective reading study by Fiona Gilbert, and she demonstrated that synthetic plus tomo performed very similarly to full-field digital plus tomo. In fact, the sensitivity and the specificity were quite similar. The second study I'm citing here by Choi looked at over 200 early cancer cases and found no significant difference looking at the synthetic compared to the full-field digital in the detected cancers, their visibility scores, and the presence of calcification. So pretty equivalent. This is a big chart summarizing a bunch of the studies looking at synthetic. I won't go through each one, but you can see from the chart that basically synthetic plus tomo performed equivalently to full-field digital plus tomo. So we don't like it as much. It's not pretty. It's a little granular. It's a little flat as an image, but at least in clinical practice, it's performing the same way. And just as a note, just to remind everybody, the synthetic is really not to be used alone. It is only approved for use with tomosynthesis. So we do a lot of outside consult work, and if they bring in a disc and they only have the synthetic imaging, that's not adequate to render a mammographic opinion. You need the tomo data too. This is just a prospective study that we did at our institution in the screening world. We haven't written it up yet, but we looked prospectively and rated the conspicuity of findings that we were considering for recall when we did batch screening. And we found that, as expected, calcifications and architectural distortion were more conspicuous on synthetic compared to full-field digital, but masses and our asymmetries were less conspicuous. And this is just an example for you of an asymmetry on full-field digital versus synthetic. The synthetic's here on the right. You can see the image is a little flatter. We've lost a little bit of that white-gray differentiation, that contrast, and so it's a little harder to distinguish it from surrounding glandular tissue. This is another developing asymmetry, full-field digital to synthetic. The full-field is down here. Here's the synthetic. The MLO spot views are really completely unhelpful because this developing asymmetry, like the one I showed you earlier, rolls right into this band of tissue, and you can't see it, even with the tomosynthesis. So these are the tomo slices, low threshold to go to ultrasound. This had an ultrasound correlate. This was a malignancy. The synthetic shows us spiculation when it's associated with that distortion, with that asymmetry. This patient has this central asymmetry here, and I have the full field cropped compared to the synthetic. You can see the distortion quite well on the synthetic. It really pops at us. And remember, that's because the algorithm is designed to enhance that feature. So just a word or two about our diagnostic workup for asymmetries. We were talking before about this. We know from our full-field digital world, these are tried and true tricks. We have rolled views, ML views, lateral medial views, spot compression. Tomo is really helpful. In several small reader studies, Tomo performed similarly to 2D spot views in assessing margins. And so some practices have started to move from doing spot views before an ultrasound to just going straight to ultrasound and reducing the number of exposures for the patient. And then I'd like to spend the last couple of minutes talking about targeted ultrasound, which we use really all the time in the diagnostic world, and the role of diagnostic MRI in evaluating asymmetries, which is a limited but sometimes very helpful one. So there's not a lot of data in the radiology literature on ultrasound findings for developing asymmetries and focal asymmetries. In fact, the largest study until recently was by Shetty and colleagues. They reported 36 benign and malignant developing asymmetries, and you'll notice from the chart 10 out of the 36 had no ultrasound correlate, and that included 2 out of 7 malignancies. Jessica Leung and Ed Sickles' paper cited here did not report ultrasound findings on most of their developing asymmetries. They did indicate that out of 21 malignant developing asymmetries. 5 out of the 21 had no ultrasound correlate. This is a third study, is a very small study, just looking at 9 benign developing asymmetries, none with a correlate. And this is the study I cited from our institution before. You'll notice we had a large number of benign and malignant developing asymmetries, and over half of them had no ultrasound correlate, including 13 out of 30 cancers that underwent ultrasound. So a negative ultrasound for developing asymmetry should not be reassuring. We drilled down on a subgroup. We looked at the 78 developing asymmetries that had an ultrasound correlate, and we looked at what the correlate was. And what was interesting is that a little over half were what we termed non-mass findings. And that's not in the BI-RADS lexicon, but that term is coming into more use in the radiology literature, particularly in the Japanese and Korean literature. They do a lot of breast ultrasound, and they're sort of using that term similar to what we use for MRI, to describe a discrete area on ultrasound that does not form a mass, but truly matches a developing asymmetry on mammography. And the other interesting thing I think about this data is that a little over half of them presented with mixed echotexture, hyperechoic and hypoechoic, and so that makes them harder to detect, right? They're harder to distinguish from the surrounding breast tissue when they're quite heterogeneous in their echotexture and they're not making convex margins. As you might expect, nearly half of them had lobular histology on pathology, because lobular we know is classic for not necessarily forming a mass. And out of the cancers, there were 21 out of these 78. 17 presented as masses, but 4 presented as non-mass findings. And this is just an example of a non-mass ultrasound finding. This patient had a little developing asymmetry in her upper breast. On ultrasound, you can see this isn't really making a mass. It's quite mixed in echotexture. It's got some hyperechoic as well as hypoechoic areas, and this was a mixed ductal lobular invasive cancer. Another non-mass ultrasound finding, she has a lateral developing asymmetry. This one actually looks like it's got a little distortion with it, but it really blends in along the planes of the breast tissue. Again, quite mixed echotexture, hyperechoic and hypoechoic. And I think in a screening setting, if you perform screening breast ultrasound, this would be really hard to pick up. So what about MRI? Well, MRI should not really be used very frequently for the evaluation of mammographic findings, but it is a common reason, developing asymmetries in one-view findings, for using problem-solving MRI when the finding after a complete diagnostic workup with ultrasound is still felt to be equivocal. You just can't decide if there's really a change, is there really something there, or is it just projectional or technical in nature? And if you look at the studies in the literature, Linda Moy did a study, and out of the ones that they considered equivocal and sent to problem-solving MRI, 85% were asymmetries. In Carol Lee's study here, 45% were one-view findings or asymmetries, that went to MRI. And in our study we reported last year, we had 294 problem-solving MRIs for equivocal mammographic findings, and over half were asymmetries or focal asymmetries with nearly a 14% malignancy rate. Just a few examples of how occasionally it can be helpful. This patient presented with a one-view asymmetry here medially. Nothing really on the MLO view. That was a stable view compared to the prior. It persisted on spot view. Her ultrasound was negative. It's a one-view finding. This case is before the era of upright stereo biopsy in our practice. She was placed into follow-up. And on follow-up, not only is the finding and surveillance getting bigger and denser, she's developed another one laterally. And everybody chickened out, and still her ultrasound was negative. So she underwent a problem-solving MRI. You can see she's got a correlate for both the medial asymmetry as well as the lateral asymmetry. The medial one was PASH, pseudoangiomatous stromal hyperplasia. The lateral one was apicrine metaplasia. Another example where we used problem-solving MRI. This is a tough mammogram. This is a 62-year-old at Dana-Farber who had a prior lumpectomy. You can see her scar here inferiorly. And she has this little asymmetry here in 2008 at the back of the breast. It's a relatively undercompressed area on mammography, right? Because the central cone of tissue, the thickest part of this irradiated breast, is in the paddle, and this is relatively undercompressed. In 2010, was it questionably getting larger? We weren't sure. It sort of persisted on a spot view. We saw it on an ML view. totally invisible on a CC view. Ultrasound, of course, was negative, and so she underwent problem-solving MRI, and you can see she's developed a recurrence at the back of the lumpectomy bed. So to summarize in the last few minutes, asymmetries, as we know, are usually due to summation artifact. Focal asymmetries are uncommon on screening and rarely malignant at baseline. A global asymmetry is usually a normal variant unless it's palpable. Developing asymmetry has a higher chance of malignancy, and it requires biopsy unless you find a definitive benign ultrasound correlate. Asymmetries and focal asymmetries are uncommon manifestations of cancer, but they are a common feature of missed breast cancer. They're tricky. They look like normal glandular tissue. Tomosynthesis will help us. It'll help us in overlap, evaluating the margins and seeing associated findings. And I think tomosynthesis should decrease the use of problem-solving MRI for these asymmetries, because we'll be able to tell more clearly where something is, if it's a real finding. And the era of upright tomo-guided biopsy should also help. Many of these findings can go straight to biopsy rather than delaying care by doing a problem-solving MRI. I think the synthetic makes it a little more challenging to evaluate asymmetries, and we have to rely a little more on the tomo data, as well as the fact that the finding has changed. And then finally, our supplemental evaluation with breast ultrasound. Remember, it may be negative, or you may actually be finding a non-mass finding, not a mass, as a correlate, and reserve MRI only for those truly head-scratching cases. Thank you. Let's see how long it takes.
Okay, all right. We're just going to switch some laptops here. Does that read? This has to go into, do you have the button? Where's the? Oh, okay. We're just hooking up my Mac so the AVIs run. So I'm Diane Georgian-Smith. I'm going to be talking now about architectural distortion. I want to first apologize that the slides that the slides you're seeing on your little thing, the content is there, but don't even bother, because we had to submit them so early that I ended up revising the talk. But the content is all there, and if there are slides that you see that are not on your thing, I'm happy to send them to you, or even go over them with you after the lecture's over. Do we need to? There we go. Oh, the point. Oh, can I use this? No, I can use this. Okay. Ooh, the aspect is, oh, there we go. Okay, great. Okay, wonderful. All righty. So this picture came up just about 2 weeks ago, and I said, this is perfect. This is architectural distortion, and now I'm done. That's it. Okay, so my objective is to actually try to assist you with the perception of seeing architectural distortion. In order to see architectural distortion, you have to know what to look for, what objective criteria to look for, what it is when it is, and what it is when it's not. Everything is in my book. That's my only thing of disclosure, so you can look it up there. Perception is this architectural distortion is the most commonly missed mammographic finding. Anecdotally, I do a lot of medical malpractice cases, and by far it is the most common finding that I see that has been missed, as well as cases of invasive lobular cancer. So, what is it? Well, Dr. Baker said to me, it is because it is. And I think that sums up perception. This is, maybe some of you have seen this, was floating around Facebook over the last couple of months, and I thought it actually captured perception. It took me a while to actually get this. It captured perception perfectly. In other words, the rhinoceros sees everything with his horn in the middle, so he paints everything with the horn in the middle. But I see it from the side that it's just an elephant lying there, and so that's what I see. And that sums up perception. Why is it that I see something that somebody else is looking at the same picture, sees it a little differently? And I don't know why, but I'm going to try to make it a little bit more objective so that you can be consistent. Because if you just rely on how it feels to you today, tomorrow when you wake up, you may feel differently, and that's not a really comfortable feeling. I think this definition in BI-RADS, frankly, is really confusing. And when I read it, it doesn't conjure up a picture. So in order to figure out what it is, I decided to do this study. And what we did was we actually got some cases, and I asked experts. We used the SBI meeting actually as a research platform, as well as my colleagues, and I asked them, tell me what you see. Describe in words, what do you see? And with that, I was able to assemble what were the most commonly spoken words of what they saw when they saw various cases of architectural distortion. And I'm just going to go through and summarize what those are. The first, number one, is that it is straight lines in a spoke wheel and radiating fashion. There can have a central density or lucency with those radiating lines. Again, the straightening of the lines, this alternating lines in the fat of white and dark bands radiating. Jose, what do I do?
I don't know.
Okay. It's like Kmart. There's a blue light special in this room.
I am clear. I think
Okay,
that
great.
works.
If any of you remember who Kmart is. And angular margins. So the perception of spiculated masses is really the same as architectural distortion. The only difference is that in the mass, you actually have the central density. You have the contents of a mass, of which it's a round and ovoid shape. It tends to be homogeneous in the central density, and you have the convex margins outward. And you're describing the spicules are the margins to a mass. So when I read a report that says, there's a spiculated mass associated with architectural distortion, I'm confused. And it sort of tells me the radiologist may be also confused. So again, the perception of seeing it, those straight lines are really the same. One has the central density and one does not. Now, this picture was taken by my colleague, Dr. Raza, on Cinnamon Hill in Sri Lanka. And she saw a beautiful peacock, and I saw architectural distortion. And this sums it up perfectly, in which there's no central mass, but you have those straight lines in a spoke wheel and radiating fashion. Now, the rear end of the same peacock is a really good spiculated mass, because now you've got that central ovoid shape, that convex margins outward, and you have those lines in a straight line and radiating fashion. And so if you get that, you got it. Okay, to optimize the image, I suggest that you make the fatty tissue on the light side, on the medium to light side, so you can see those lines that are radiating in the fibroglandular tissues that are not at the center. So let me just kind of point out what that is on this picture. What you're looking at are the lines out here away from the central density. You want to actually be able to interrogate and see the straightening of these lines out in the fat. And so regardless of whether there's a central density or not, this out here in the perimeter is really what's going to give it away. So in contrast, what if it's not architectural distortion, then what is it? So it's summation tissues, again, just like what Kathy alluded to with the asymmetries. It's summation tissues. And the contrast is that will have curved lines. So just think of what makes lines on a structure on a mammogram. The Cooper's ligaments, blood vessels, they're curved. So if you're interrogating a certain area, again, whether it's on tomo or whether it's on full field digital with 2D, if you see that these are crisscrossing of curved lines, you can go and you can actually say that this is summation tissues. Again, they're Cooper's ligaments. There are no straight lines in the body. And I remember somebody telling me that as a resident, and when you think about it, I said, boy, that's really kind of heavy thing. But if you think about it, no matter whether you're looking at a chest x-ray or abdominal film or CT, if you see something a straight line, you better focus on that and figure out why is there a straight line there. Now, is it an artifact? Is there a fracture? What else is going on there? So there are no straight lines in the body, and I think even in plants, and it is kind of a really interesting concept. Okay, so because of tomosynthesis, detection of architectural distortion is easier. So these are some examples. And again, we're looking out here, we're looking for those straight lines in a radiating fashion. This is the, I think this is the CC view. This is the same picture. This makes me same lesion, but in the other projection. Again, out here, these straight lines that are out here in a radiating fashion. And that we can see, and this did not show up on the 2D and only showed up on the tomo slices. A spiculated mass, again, I don't care that it's actually mass. We're looking out here in the fat, the straight lines in a radiating and spoke wheel fashion out here near the nipple, again, in that location. In contrast, there's no central density. This is a complex grossing lesion. These are the straight lines out here, right in here, out here, okay? These are straight lines, again, in a spoke wheel fashion. This is the area here in the other projection, in the medial lateral projection. There are lines here. Wonder if they actually are projecting. Okay, out here and out here. So that's what you want to train your eye to see, again, is those straight lines. This is what it actually looks like, architectural distortion in fat necrosis. And what we're seeing here is this is adipose tissue, these white portions, this is adipose. This is going to be fat, whereas anything that is pink or purple is going to be white. And so you can actually see that it's making a sort of these straight lines in a radiating spoke wheel fashion. And that's what we're translating into X-ray. So here's, again, another example. This was of adenosis associated with some calcifications. This is the location of, again, distortion. Again, these lines out here, out here, out here. And same thing in this projection here. This is also an MLO view. These are different tomo slices. This is the CC view of the same thing. Again, these lines out here in straight lines in a spoke wheel and radiating fashion on the tomosynthesis. A callback for possible. Now, this is in the contralateral side of that last case I just showed you. And the question that here was on 2D, we didn't see anything, but my colleague was wondering of whether there was architectural distortion on the contralateral breast. And I think it's a very, very reasonable call. You're looking for maybe this is a spiculated mass, and then again with lines out here. And so this is that same picture, and then on the tomo, oh, it switched. Okay, these are lines coming through, and again, all of the lines in this area, these are coming through, and again, we're not getting any straight lines in a spoke wheel fashion. This actually really did, well, I think we're just going to move on. So because of tomosynthesis, I think also now it's harder to figure out when it's not architectural distortion, for the same reason as why we're actually seeing it. So let me bring this back to pathology and why that is so. So this is actually an inflamed cyst. This is that thick wall cyst on ultrasound. This is the cyst that enhances on their wall at MRI, but I didn't show it for that reason. What I showed is that if this is all soft tissue density, because we got the duct filled with fluid, and then all the gray where there's fat here is going to be, again, of adipose density here and here, and we saw this whole thing as a straight line on tomo, and so now we've got gray and then white and then gray. We could easily think that this is, in fact, if this we're looking at it whole, actually one of those spoke wheels. And so we're getting that detail now with tomo that can make it quite challenging to actually figure out, is it real or is it just summation tissues? So I wanted to actually go through cases that were called back for architectural distortion that we ended up calling summation tissues. Because it's dandy to have a bunch of pictures here and say, oh, this is distortions, distortion, distortion. Okay, don't you get it? No, the hard part is to try to figure out when it's not, and that you feel comfortable in saying this is not architectural distortion. So let me try to go through and why it's not. So this was the 2D, the combo of the MLO and the screening. And again, this certainly looks like this is a radiating area of lines in a spoke wheel fashion. And boy, I hope the architecture, the TOMO works. Okay, so this is going to be, well, shoot. Okay, so in the area we're looking in here, and again, the lines are coming in and they're just going straight through. We're lacking that spoke wheel pattern. So let me go ahead and keep clicking on it. And the same kind of thing, we're looking at these lines going through. And it should keep going. I don't know. And it's not going. But you're just going to have to take my word for it. But that's, again, what you're looking for is in those TOMO slices, are you continuing to see that spoke wheel pattern, or are now, in fact, the lines actually going through, or are they curved? Okay, so these are, again, we see this actually quite commonly, particularly in these areas where we're going to get the Cooper's ligaments kind of on the side. This was called back for possible architectural distortion. These are the TOMO slices of it, the respective MLO of a on TOMO. And again, this is why distortion on TOMO is getting to be so hard, because we're actually seeing these individual lines between the fibroglandular tissue and the fat. This is the corresponding ML TOMO slice. And again, these lines are all coming through like this. This is curved, okay? But we're lacking those straight lines that are in a radiating or spoke wheel fashion. This was actually a case that was recommended for biopsy, and let's see how this TOMO goes. So at the time of the TOMO-directed core biopsy, this didn't persist. And let's see how well this shows up. So it's going to be right in here. And again, you can see that this is just going through this way. We're lacking those straight lines in a spoke wheel fashion out here in the fat. And let's see if it's still running. So much for trying to get those AVIs to work. And it's not moving. Sorry about that. Okay, so architectural distortion, if you're going to find the small cancers, you really have to be comfortable with the false positives, those cases that turn out to be summation tissues. There's nothing wrong with it. We're doing a screening study that is going to be highly sensitive but not very specific. And so it's okay. It's okay to say, gee, I'm not certain that on the TOMO it's architectural distortion. It kind of looks like it may have a spoke wheel fashion, and then it turns out to be summation tissues. That is okay, and you need to be comfortable with this concept to finally find those really, really small cancers. So I was able to illustrate sort of the perceptual features of architectural distortion, the perceptual features of summation tissues, where they're going straight through. You're lacking that spoke wheel fashion. You're lacking those straight lines. Okay, it looks like I have a little bit of more time, and I'm just going to, on the topic of architectural distortion, talk about the reporting of architectural distortion. And so it's a little bit of a tangent to this, but I think I'm going to just take the opportunity of being up here, kind of on the pulpit, and talk to you and try to make certain that your reports are, in fact, defensible. So as I said, I do a lot of medical malpractice cases, and architectural distortion is the most common thing that I see, and the reports that I read really get radiologists into a lot of trouble. And so it does behoove you to read your reports carefully, definitely fix any spelling errors. They will, if they during a deposition or if you're up on the stand, they will go through each and every word and ask you to define it. And if you look like you're saying something that's ambiguous, or there are, spelling errors and things like that, then you look sloppy. And so again, as if anybody went to Dr. Monticello's talk yesterday, the peers are not people like yourself, but of just, as I think she said, the shoppers at Walmart. So, but again, they come from all over. And so you really need to put your best face forward. So some cautionary tales. Because the positive predictive value of architectural distortion is so high, you've got to biopsy it. Architectural distortion isn't like, I see architectural distortion, I'm going to go ahead and follow it. That's not acceptable. You have to go ahead and recommend a biopsy when, in fact, you think it's real. So do not follow architectural distortion. It seems like a simple message. Well, let me tell you how that kind of gets messed up. So this was actually a case from a lawsuit where the radiologist on the screening report said there is architectural distortion in the upper outer quadrant of the left breast. Well, to a lawyer, and that's a fact. That person said there is something that's there. And then the radiologist, and she came back for her diagnostic workup. It turned out to be summation tissue, put it in 6-month follow-up, and then sure enough it turned out to be a cancer, and then it grew. And now this radiologist has this situation where, well, doctor, you said it was there, and now you say there isn't there, and now this is where it grew. Don't you know what's going on? So in your screening report, remember the screening examination, if you call that patient back for additional views, it's not an abnormal exam. It's incomplete. You need additional data to figure out whether the finding is real. Okay, is there really a mass there, or is it just fibroglandular tissue? Is it really distortion, or is it just summation tissues? So it's it's incomplete exam. So what we tend to do, or what I tend to do, is say there's a questionable area of architectural distortion versus summation tissues, because then it will allow that radiologist who's now on the diagnostic end of your callback, which could be yourself, sometimes, to have that flexibility of saying, no, it's not really architectural distortion here, it's just summation tissues. But if you call it and say that there is, that is now considered a statement of fact. And now you're going to have a really hard time if, in fact, it's not actually real. The BI-RADS 3. Okay, the BI-RADS 3 category is not a place where, say, well, gee, I don't really know there's distortion here, so let me just see what happens in 6 months, and then we'll kind of figure it out. Okay, that is not BI-RADS 3 in anybody's definition. The BI-RADS 3 category are for things you think are benign. Things you think are benign, and that they're better be based on the literature and your experience and perhaps the audit of your practice and so forth. And so it should not be. So for instance, I've seen indications, so follow-up summation tissues, and 6 months later it says follow-up of architectural distortion. And I was like, no, we don't follow architectural distortion, we biopsy architectural distortion. So that if in fact that turns out to be cancer and a delay in diagnosis, now you really are, you're bailing yourself out. So we don't follow architectural distortion. So it's not an appropriate place to have that in the indication. This was actually words of a report that I read, not from one of my colleagues, of course, never, where it said negative mammogram and ultrasound. However, the original MLO image shows a questionable distortion. And right now, I'm confused, okay? I'm on the receiving end as I said, well, the radiologist says there isn't anything on the workup, but there still may be on the original one, so we'll just bring her back in 6 months. So that concept where I said, BI-RADS 3 category is not for the, well, gee, I don't know what's going on, so let's just figure out what happens. Seems like a simple concept, but this is, in this format, this is how that translates. It's like, well, I'm not really certain. I see it originally, but I don't see it today, so we'll just see what happens. Okay, so that's not the right report. For the same set of images, here's a suggested way of actually displaying it. And say, probably benign summation tissues. Because, well, why do you think it is? So now, as I said, I went through some objective criteria that goes into distortion, straight lines in a spoke wheel and radiating fashion, okay, versus lines that are not, that are actually going through. So you say, because there are no signs of distortion. So Dr. Georgian-Smith, what are the signs of architectural distortion? And I'll say, straight lines in a spoke wheel radiating fashion. There are none here. So if I was actually ever deposed or have to define what I said. So I'll say, why do I think it's summation tissues? Because there are no signs. So recommend short interval follow-up, document stability. And now, unlike the last one where it says document stability, I'm not certain in this format, in this sort of stability of what? The questionable distortion on the screening, or the fact that that this person thinks it's negative? I'm not certain what stability they're trying to get at. Whereas in this type of report, it says stability of summation tissues. So one suggestion that I'll commonly say to the residents is that if you, whatever category you're using, whether it's BioRads 3, start your sentence with that and be able to explain in your head why you think it's a 3, or if it's a benign calcs, why are they benign? Benign calcifications. Why? Well, maybe they're teacup, maybe they've been stable for 2 years, maybe paucity of a number. Why do you think it is? And that is a defensible report. It may be wrong. It may turn out to be cancer in 6 months or 12 months. But if in fact it is based on what's reasonable, and you can in fact defend it and say, well, in these images, on that data that I have today, there were no straight lines in a spoke rating fashion, that's defensible. And so that's my point. So in summary, I went through the features of how to analyze distortion versus summation tissues, correlation with the histopathology to try to help you understand what you're seeing on the imaging, and some cautionary tales with reporting. Thank you very much. Yeah, we do have some, we've got about 10 minutes for questions. Is Jose out there? Can he put the lights up? Or can somebody hit the?
We have one here.
Sure.
What do you think about sometimes if someone calls back for a possible architectural distortion, and then after diagnostic workup you rename it focal asymmetry if you think it has these characteristics? I mean, sometimes there is kind of a focal density there in two views. I don't think that really applies to the real.
I guess that confuses me.
Do a 6-month follow-up.
So to me that's it. So what I'm hearing is that at the time of the workup, you don't think it's distortion, but really what you're saying is that there's summation tissues, that there's that it really is a. So the question is, if you have what you think is maybe a developing density, like now there's a new density there that was not there. No.
It's not really distorted. It's just a focal asymmetry. That's why
Okay, well, again, because it's really summation tissues. In other words, is it really? Right, so we're looking for mass calx architectural distortion. So are there now features of a mass, yes or no, ovoid shape, homogeneous in density, convex margins outward? Okay, no. So then if it's is it distortion, or is it with straight line spoke wheel fashion, or not? And if it's not, then it's summation tissues. So I get a little bit confused we're going from evaluation of if we're on the 6-month follow-up, we're not following distortion, we're following summation tissues. And you want to just ensure that it stays looking like summation tissues, that it doesn't now the tip of the iceberg and now be all of a sudden, now I actually see distortion due to maybe perhaps differences in the way the breast compressed, or now it's growing. Does that answer your question?
Yes.
Okay.
Thank you.
Here.
Can you talk about after biopsying architectural distortion, the list of diagnoses that you would accept as concordant?
Oh, do I have to? Isn't that on the program elsewhere? That's a good question. So obviously, it's easy if it's the radial scar and complex grossing lesion, and obviously if it's cancer. So you're talking about the benign stuff. And in order for the pathologist to actually call that radial scar, complex grossing lesion, they need that nidus. They need the thing that looks like an octopus. But what if you chopped off the legs of the octopus and just a portion of the body, okay? And so they're not actually got all the pieces of the octopus. So do you have just the legs, and is that concordant? So first I'm going to chicken out a little bit and say, obviously you should do your own audit. That's a way to get out of here, like do your own audit. When I'm doing my biopsy, I will also look to see where the clip is, and I will get really well compressed, not these undercompressed, tomo views in both projections to see if in fact the clip is actually in the center of it. And then what you're asking is, will I, and maybe the elephant in the room is, will I follow distortion that's benign that I think that I hit? She's my boss. I don't know if I really want to go there. It's controversial. I have to say that I have followed it. The longest patient I have followed now is 4 years, and I felt it was very, very small. I'm not talking about a 2 centimeter thing. I'm talking about something that was about 5 or 6 millimeters, and I hit it squarely under ultrasound, and the clip was in both views, and it was actually our pathologist, Susan Lester, who said, gee, if you're really all over this thing and we're not getting any atypia, what are the chances that there's still cancer there? And it's one reason why I think we're going to be looking at it, in our results and doing a study and so forth, and that's why I said do your own audit. But that's what got me thinking, and I said, gee, so I told the patient, I said, 4 years ago, I said, it is practice to now do surgical excision for these things after a benign biopsy. But I feel fairly confident that I hit this, and I'm willing with Tomo now to follow this, because I feel like I can see it better now with Tomo than I did with 2D. And it was just sort of anecdotally. And then she said she was willing to take the chance, and then she told me what her profession was, which was a law professor over at Boston University in medical malpractice. And then she actually sent me a Christmas card this year, which was very cute. And she said, it looks like you were right. Okay. I thought it was like, I'm going to sue you. But again, I would not, I wouldn't, there really needs to be studies. Okay, and there needs to be very well controlled. I think that's why our practice, I think Dr. Quaid is going to be looking at it and so forth. And so that's why I say to do your own audit.
Can I just add to that? We've had sclerosing adenosis present as distortion, and I think.
Oh, that's a good question. Yeah, why don't you come up here? Yeah.
I was just going to say we've had sclerosing adenosis present as architectural distortion and have accepted that, and I think that's supported in the literature. Fat necrosis we've had present as distortion, and we've accepted that. My one caution would be if you get stromal fibrosis when you're doing a tomo biopsy or a 2D biopsy of distortion, that's not necessarily concordant, and we've had 1 or 2 cancers, little cancers, where we got stromal fibrosis, and then in follow-up we picked it up. So I don't know if that's really a concordant explanation. Yeah?
Global asymmetries on a baseline exam, do you call them back to examine them, or do you just trust that they have impossible masses? Or?
Yeah, that's a good question. I think on a baseline, did someone say repeat it? Global asymmetry on a baseline, are they called back? Are they a BI-RAD 0? And I would think in our practice they are called back, they're evaluated, we make sure we don't see an ultrasound finding, and that they're not palpable. Yes?
I just want to throw out a thought that I'm not sure it's ever okay to put a BI-RADS 3 on a finding that you describe as even possible distortion, because let's say in the workup you're not seeing evidence of a distortion, then it begs the question, why are you bringing this patient back? Because you still have some degree of uncertainty. It's not that you think it's polybenign, you're uncertain if it's a real finding to begin with. And I feel like that's
No. It's not, again, BI-RADS 3 is not when you're uncertain. BI-RADS 3 is like, again, the question in the diagnostic workup is it real? And your workup, you get to the point with the pictures you get, the tomo views, the spot views, the roll views, whatever you want to get, that you don't think there's distortion there. Now, you could just say, return her to screening, okay? Right, or again, it depends on the level of the confidence of the different radiologists. But it's not, but it's that you think there is no distortion there. And I think, yes, to actually say BI-RADS 1 and this is negative, there's no distortion, I think that's actually very, very, that certainly is possible. But you could also say, gee, she's very dense, she's got a lot of stuff going on, I want to make certain that this area of summation tissues stays looking this way.
Okay, so in 6 months, distortion could still be distortion,
Well, let's say, let's say it's an invasive lobular cancer, and in spite of all the data you're presented with, that there are no straight lines in a spoke wheel pattern, you really want to make certain that this is the way it's going to stay. And so it's just, again, biopsies are for things you think are benign, but you just want to make certain that it's your expectation. And I learned this at an SBI meeting 30 years ago, that your expectation in 6 months is that it is going to stay benign. It is not, well, let me see if there's a little bit if it's going to change. You expect to see the exact same thing. So it needs to be, the diagnostic workup needs to get to that level of certainty is my point. Yes, sir. Sure.
For how long do we keep following benign results as a diagnostic, and then when should we return to screen for a benign pathology and for the distortion? And then the second question is, why would you consider stromal fibrosis as the score?
Well, let me do the first one. So you're asking after you have after a benign biopsy of architectural distortion, how long you follow it for? You know, that is still really controversial. I do not want to be quoted to say you can go ahead and follow it. I really do think that it's going to take more study. It definitely takes an audit of your practice to get to that level. And I gave you an anecdotal, I was willing to go out with this patient and to try this. So, yesterday you saw on the panel, everybody else continued to, wanted to do surgical excision. So I think until you look at your own practice, I think you'll be able to answer that. So, as with the previous question, if it's summation tissues, then you could theoretically just turn it back to screening. If you still have architectural distortion, but it's truly like one of those cases that I showed, a small 1 centimeter architectural distortion, we don't know. Because it's not. I know. And the standard of care has been that it's been a follow-up to surgical excision, that it goes into the bucket unless it's incidental. And so we don't know. We really don't we don't know which way we can definitively go with that. And I'd say most of the literature is saying that you need to do surgical excision, but there are definitely studies coming out and suggesting that particularly if you get a radial scar, you actually get something that mimics that actually explains why you have the distorted area, like a radial scar, that there may be some suggestion that you could go ahead and that there is not an increase in biopsy, upgrade rate. But it's still very controversial. So I can't answer that because it's just still not standard of care not to send her to surgical excision. So I would just say, you look at your own practice. Definitely look at your own data. Look to see, in fact, how many, change over time. Audit your practice. And I forgot, your second question.
In our experience, some of those tiny little distortions that we need to use tomo guidance to biopsy, they're actually quite challenging sometimes to biopsy. They're lucent, they're hard to see, you got 1 or 2 slices to target, and some cancers have a lot of fibrosis associated with them. So anecdotally and also I think pathologically, you may clip part of it and get fibrosis and miss the cancer cells. So I would be cautious about accepting that unless you feel like you've really sampled it, your clip's dead on, you've taken extra cores. I'd be a little careful about accepting that. We typically will excise it. Yeah.
We'll take one last question.
Yeah.
We've done many tomo-guided biopsies, and
Can you go to the microphone, ma'am?
we have done a lot of tomo biopsies, and we find there's a lot of distortion after biopsies. So to follow a distortion with a benign histology doesn't work because you have more distortion after the biopsy. So, we don't follow distortion
because of that reason. There's a lot more distortion because we want to get an adequate sample, so we tend to get more tissue with a 9-gauge needle. So when they come back, even for a month later, because they had a big hematoma and we couldn't do the post-mammo, they have so much distortion, it looks much worse than what you start with, and those are very hard to follow, I think.
Yeah, that's a good point. We debate that too, actually, in our group, that it can be very hard to follow distortion after benign, especially when they're large. Because if you have a 2-centimeter area of distortion, how do you know if it's partly changing? So we debate that too. But do you then say that you take them all out after you do a biopsy?
If the initial lesion was distortion, and if it's not radioscar or cancer, we send them to surgery.
Yeah, yeah. Yeah, I think as Diane said, that's still evolving, and I think a lot of people do the same. Allison? No. Can you?
Or you know what? It's after 4. We should let everybody go. Why don't you come on up? Al?
Yeah, anybody with questions, come on up.
All right.
Thank you.
Yeah.